My name is Dr. Catherine McBride, and this is a case-based reflection on upholding ethical principles for a pessary replacement in a non-English speaking patient. So for patients who speak a different language, the gold standard is to use a professional interpreter. Our hospital is based in a multi-ethnic area where a substantial proportion of patients don't speak any English. So professional interpreters are booked for clinic appointments, and then we use language line in the acute setting. An elderly lady presented to the emergency department with urinary tract obstruction secondary to uterine prolapse. Language line was used to obtain the history and explain and gain consent for an internal examination and pessary replacement. However, when the patient struggled to tolerate the examination, it became near impossible to guide her through it due to the language barrier. Rather than asking the patient to redress and call back language line, the patient's granddaughter attended with her and was eager to help. She held her grandmother's hand and translated feedback on the progress of the examination and pessary replacement. The patient's face transformed from a picture of discomfort and fear to a relaxed smile as she nodded to her granddaughter's words. On completion, language line was used again to explain the findings and the management. In this case, the presence of a relative as a second interpreter significantly aided the assessment. Instead of prolonging an uncomfortable assessment by asking the patient to redress and wait for another telephone interpreter to answer, the examination was completed promptly. Due to the patient's presenting complaint, she was already in discomfort and self-conscious. To combine this with the confusion she developed during the examination quickly escalated to fear. As doctors, we strive to do no harm, with patient welfare being at the core of our practice. In this scenario, the words of assistance and reassurance from a loved one enabled us to maintain patient well-being and dignity. Patient autonomy is a core value in Western medicine. There was a temporary loss of autonomy when the patient became fearful, which was recovered because of the aid of the granddaughter. To give informed consent, a patient requires adequate understanding, which this relative provided throughout the examination. It could be argued that we did not ensure justice for this patient, as a similar patient may have been provided with a professional interpreter for the entirety of the assessment. However, in this case, the reassuring guidance provided by the granddaughter gave immeasurable relief to the patient. The core principles of beneficence and non-maleficence were key in opting for the utilisation of the granddaughter as an interpreter in that precise moment. Cultural elements were also in favour of this, as the patient was comfortable with this situation.